Are you taking amlodipine, losartan, or lisinopril for your blood pressure? Same pill every morning, same glass of water. But how well do you actually understand what that medication is doing inside your body right now? Not what the leaflet says. I mean, really understand it. How it works, how it can cause a problem under certain conditions, and which signs tell the difference between a minor inconvenience and something that needs urgent medical attention. These aren't mild medications. They change how your heart, blood vessels, and kidneys work every single day. And millions of people take them on autopilot, without knowing what to watch for, what to avoid, or when something that feels ordinary is actually your body trying to send you a signal. Today we're going through these 3 medications, point by point, in a way that makes you more aware and less caught off guard if something changes. A quick note, this video doesn't replace an accurate diagnosis from your doctor. It's for informational purposes only. What you're about to learn can help you understand your treatment better, not change it on your own. Any concern or change should always be discussed with your doctor or pharmacist. Thanks for watching, let's get into it. Point 1. 3 different medications, not the same thing. Amlodipine, losartan, and lisinopril all lower blood pressure, but they do it through completely different mechanisms, and that matters more than it sounds. Amlodipine is a calcium channel blocker. It relaxes the muscular wall of your arteries, so blood flows with less resistance. Lisinopril is an ACE inhibitor. It blocks an enzyme that narrows blood vessels, and blocking it brings pressure down. Losartan is an ARB, an angiotensin receptor blocker. It works on the same system as lisinopril, but it blocks the doorway the signal needs instead of stopping the signal from being made in the first place. 3 different mechanisms means 3 different side effect profiles, and understanding that difference helps you read your body's signals correctly instead of lumping everything together. Point 2. Leg swelling with amlodipine. This is one of the most common and most misunderstood side effects in all of blood pressure medicine, affecting a meaningful share of people who take amlodipine, with studies reporting rates between 15% and 46% depending on the dose. Here's what's actually happening. Amlodipine relaxes the small arteries in your legs, but it doesn't relax the veins to the same degree. Blood flows in more easily than it flows out, pressure builds up in the small vessels near your ankles and feet, and that pressure pushes fluid out of the vessels into the surrounding tissue. The result: puffy ankles, socks that leave marks, shoes that stop fitting, legs that feel heavy by evening. This isn't fluid retention from too much salt. It's not your kidneys failing. It's not the start of heart failure. In most cases, it's simply a predictable result of how this medication works. What actually makes this risky isn't the swelling itself, it's how people respond to it. Some people see the swelling and decide on their own to stop the medication without telling anyone, and their blood pressure quietly climbs back up. Others keep taking it but start drinking less water, believing they're retaining fluid. That's the wrong direction, since dehydration on a calcium channel blocker carries its own risks. Others simply put up with the swelling for months, cutting back on activity and losing quality of life for no reason. The right move is simple. Leg swelling on amlodipine is something to tell your doctor about. Not because the medication is necessarily wrong for you, but because there are real adjustments available, elevating your legs, changing when you take your dose, or in some cases considering a different medication. There's also another approach your doctor may consider: adding an ACE inhibitor or an ARB to amlodipine therapy. These medications also act on the veins, not just the arteries, which partly rebalances the pressure in the vessels causing the swelling. Clinical studies have shown this combination can reduce the rate of edema compared with amlodipine alone. But none of these adjustments happen if the problem stays unspoken. Point 3. The lisinopril cough, and where the real emergency begins. Lisinopril has a well-known side effect in its drug class: a dry, persistent cough that often gets worse at night and doesn't respond to cough drops, lozenges, or antihistamines. It affects somewhere between 5% and 20% of people who take it, more often women. The tricky part is that it doesn't always start right away. Sometimes it shows up weeks later, sometimes months later, and by then the connection to the medication is rarely made. People blame dust, allergies, a lingering cold, or reflux. Now, something critical, because there's a distinction here worth holding on to. There's one symptom in the ACE inhibitor category that isn't just a nuisance, it's a medical emergency. If you're on lisinopril and you notice swelling of your lips, tongue, face, or throat, especially if breathing or swallowing becomes difficult, you don't wait. You don't call the office tomorrow. You call emergency services right away. This is a condition called angioedema. It's rare, with an incidence between 0.1% and 0.7%, but it's real, and it can close off your airway faster than you'd expect. A dry cough is a nuisance. Throat swelling is an emergency. That difference is worth remembering. Point 4. Why your doctor sometimes switches you from one of these to another. Here's something worth knowing, because it explains why certain medication switches aren't a sign that something went wrong. ACE inhibitors like Lisinopril and ARBs like Losartan are considered equally effective in international hypertension guidelines. Neither one is stronger at controlling your numbers. The difference shows up in safety. A comparison of nearly 3 million people starting treatment for the first time found that those on an ACE inhibitor had more than 3 times the likelihood of edema or angioedema, and about a third higher likelihood of persistent cough, compared with those on an ARB. So if you developed a cough or swelling on Lisinopril, switching to Losartan isn't a downgrade or a guess. It's a class change backed by real data. Point 5. The hidden potassium risk with Losartan and Lisinopril. This is a risk that catches exactly the people trying to do the right thing. Both Losartan and Lisinopril act on a system that also regulates potassium in your blood, and they tend to raise it slightly. For most people, this stays in a safe range when monitored. But certain common habits change the picture. Potassium doesn't just come from bananas or supplements. It's hiding in products marketed as the healthier choice, salt substitutes. Many popular low-sodium salt alternatives, sold right next to regular table salt and often labeled heart-healthy, replace sodium with potassium chloride. So someone who's been told to cut back on salt picks up a potassium-based substitute, uses it generously on every meal, and ends up loading potassium into a body that's already retaining more of it because of the medication. When potassium climbs too high, it can disrupt your heart's electrical rhythm. The signs aren't always obvious. Muscle weakness, persistent fatigue, leg cramps, tingling in the hands, a heartbeat that seems to skip. Sometimes there are barely any symptoms until things get serious. If you use a salt substitute and take Losartan or Lisinopril, that's worth mentioning to your doctor. Not because the salt substitute is dangerous on its own, but because the combination, left unmonitored, can create a problem that never needed to happen. Point 6. What happens to these medications when you get sick? We're not talking about a hospital stay or a serious illness. Just a stomach bug, a few days of vomiting or diarrhea, low appetite, or even a hot week with heavy sweating and not enough fluids. When your body gets even mildly dehydrated, the same dose of Losartan or Lisinopril that worked perfectly well before can behave differently. Your blood pressure can drop too far. Your kidneys, already under strain from fluid loss, become more vulnerable. Dizziness, weakness, lightheadedness, or acute kidney stress can show up faster than expected. The medication hasn't changed. The internal environment it's working in has. That's why it's worth having a plan ready before you ever need it. Whether to hold your dose, when to call your doctor, which symptoms should prompt a visit. If you don't have one, it's a simple question to ask at your next appointment. What should I do with my blood pressure medication if I get a stomach virus or can't keep fluids down? Point 7. The over-the-counter pain reliever almost nobody connects to their blood pressure medication. Arthritis flaring up, a sore back, and you reach for ibuprofen like you always have, without thinking twice. If you're also taking Lisinopril or Losartan, and maybe a diuretic on top of that, this combination, used regularly, can meaningfully reduce blood flow to your kidneys. Add even mild dehydration, and the risk of kidney injury rises in a real way. The reason this slips through so often is simple. Ibuprofen feels like just something from the drugstore, not a real medication in the same category as a prescription. But your kidneys don't distinguish between over-the-counter and prescription. They respond to chemistry. If you regularly use anti-inflammatory pain relievers for joint or back pain and you're on one of these blood pressure medications, that's worth a conversation with your doctor. Safer alternatives for your kidneys often exist, like acetaminophen or topical treatments. Point 8. The dizziness that almost everyone underestimates. That brief wobbly moment when you stand up from the couch or get out of bed in the morning. The room tilts for a second, you grab something, and it passes. For a lot of people on blood pressure medication, this happens regularly, and it's almost always brushed off as too minor to mention. Here's why it matters. In older adults, a few seconds of dizziness is enough to cause a fall, and a fall is enough to cause a fracture, which can change someone's health trajectory for years. The dizziness happens because the medication is doing exactly its job, lowering blood pressure, and when you stand up quickly, your cardiovascular system hasn't had time to catch up. The fix is usually simple. Rise slowly, sit on the edge of the bed for a moment before standing, hold on to something stable. But if the dizziness is frequent, doesn't improve after the first few weeks, or comes close to fainting, that's worth reporting. It may call for a dose adjustment or a review of your medication combination. Point 9. What time of day should you take it? Here's what the science actually says. There's been a popular idea floating around that taking blood pressure medication at night, instead of in the morning, protects your heart more. That idea came from a handful of smaller studies that seem to point that way. But the largest, most rigorous study ever done on this question, called the Time Trial, followed more than 21,000 people for over 5 years, comparing morning dosing with evening dosing. The result was clear: no meaningful difference in the risk of heart attack, stroke, or cardiovascular death between the two groups. A broader review in 2024 confirmed the same finding. So if you've heard there's a right or wrong time to take these medications, the most solid answer we have today is this: take it at whatever time you're most likely to remember and stick with every single day. Consistency matters more than the exact hour. Point 10. One reading is not a verdict. Blood pressure isn't a fixed number. It moves throughout the day based on dozens of factors. How you slept, whether you had caffeine, pain, anxiety about the reading itself, a walk you just took. A high reading on a random Tuesday morning after poor sleep doesn't mean your medication has stopped working. A low reading after a hot day doesn't mean your medication is too strong. What matters is the trend over time, measured consistently. Same arm, same time of day, after 5 minutes of quiet rest. People who measure inconsistently and react emotionally to single numbers tend to make decisions that don't actually help. Extra doses out of fear, skip doses because one reading looked good. Keep a method, follow the trend over time, bring the data to your appointment. It's far more useful than one alarming screenshot. How it all fits together. These 3 medications don't remove the underlying cause of high blood pressure, they manage its effect. Amlodipine reduces how tightly your arteries constrict, but it doesn't repair the stiffness that built up over the years. Lisinopril blocks the signal that narrows your vessels, but it doesn't fix the vascular changes that made that signal too frequent in the first place. Losartan locks the door that signal needs, but the signal is still being sent. All 3 manage the system's output, not the cause behind it. That's why ongoing checkups matter more than the first prescription, and why lifestyle isn't optional. Diet, sleep, weight, and movement work alongside the medication, not instead of it. One boundary always applies: none of these medications should be stopped or changed on your own. Any change, any concern, anything that worries you belongs in a conversation with your doctor, not handled alone. Where to start? 5 practical steps to put this into action. 1. If you take amlodipine, watch for evening leg swelling, and if it's there, bring it up at your next checkup instead of ignoring it or stopping the medication yourself. 2. If you take lisinopril, keep the distinction in mind between a persistent dry cough, which can be reported calmly, and swelling of the lips, tongue, or throat with breathing difficulty, which is an emergency you call in immediately. 3. If you use a salt substitute and take Losartan or lisinopril, check the label and talk to your doctor before continuing to use it regularly. 4. If you regularly use pain relievers like ibuprofen alongside one of these medications, ask your pharmacist if a kidney-safer alternative exists. 5. Measure your blood pressure the same way every time, same arm, same time of day, and bring the trend over time to your next appointment, not a single isolated reading. If this video was helpful, leave a like. If you have constructive feedback for me, write it in the comments. Lastly, subscribe to the channel to stay updated, and see you in the next video.